everyone. So I'm Fionnuala Cormack, and I'm a nephrologist at Harborview, as most of you know, and I also see stone patients at the Kidney Stone Center at Northwest. So today, the title of my talk I decided upon was From Uricid K to Moonstone, the story of citrate and kidney stone disease. So a little bit of, we'll go through a little bit of history of treating hypocitraturia. For the outline of my talk, I'm going to, let's see here. Just one sec, I think. Okay, sorry about that. All right. First, talk about the proximal tubule and citrate handling, followed by factors that influence urinary citrate, etiologies for hypocitraturia, and we'll define that, and then strategies for treating hypocitraturia in kidney stone disease. So this wouldn't be a stone talk if I didn't start with a 24-hour urine collection. So this is a patient that I saw in the stone center, 40-year-old gentleman who's had recurrent kidney stones. This is his first 24-hour urine collection. And you know, if you don't know anything about stone disease, you can just use the color coding. So if it's a value falling in this orange section, then it's considered increased risk for stone disease. And of course, because we're talking about citrate, you see here that this patient has a urinary citrate of 107 milligrams. So there are 4 domains to citrate homeostasis: dietary intake, GI absorption, kidney metabolism, and of course cellular metabolism, which most of us were introduced to in medical school. And also the bone is actually a major reservoir for plasma citrate. So my focus today, will be on how obviously the kidney handles citrate and citrate's role in metabolic stone disease. So 95% of dietary citrate is actually absorbed in the small intestine by a NADC1 co-transporter, and this is a transporter we'll talk about in a few slides because we'll see it again in the proximal tubular cells. So interestingly, 98% of citrate is metabolized in the liver to bicarbonate. So a very tiny amount of citrate actually remains unchanged in the plasma. And since the highest pKa for citrate is below physiologic pH, citrate is predominantly in the trivalent form in plasma. And so again, circulating levels are quite low, about on average 0.05 millimole to 0.3 millimole. And much of it is complex to divalent anions like calcium and magnesium.
Hey, Fionnuala, sorry, I'm sorry to interrupt. I feel like the sides of your slides may be cut off slightly.
Okay.
I don't know if you want to just try.
Let me see. I don't know. Okay, let me see here.
It's not a huge deal if we can, but.
Okay, does that look better?
Maybe just go back to the last slide.
Okay.
Yeah, that appears to be better.
All right. Okay, so we're going to talk now about renal clearance of citrate. So factors influencing urine citrate, and this is our proximal tubular cell. So before I discuss citrate handling by the proximal tubule, I'm just going to briefly review the kidneys and their role in acid-base balance. So these next few figures, the next few slides are going to show figures from an excellent overview of proximal tubular function in response to acidosis. So as we all know, the proximal tubular epithelium is perpetually excreting hydrogen regardless of diet. And in so doing, the proximal tubule reclaims about 79 to 90% of the filtered bicarbonate load. So 2/3 of hydrogen is secreted by this luminal sodium hydrogen transporter, which is electroneutral. and then a smaller amount by this proton ATPase. So again, as we all know, hydrogen combines with filtered bicarbonate, and then we have this luminal carbonic anhydrase, which essentially catalyzes the production of CO2, which then facilitates this reclamation of bicarbonate. So additionally, the proximal tubule, as you know, is responsible for excreting acid. So the urine can't maintain a pH low enough to accommodate 50 to 70 milliequivalents of free hydrogen, which is essentially a product of the Western diet. So the proximal tubule produces both ammonia and also facilitates luminal secretion of hydrogen. So we have, again, this is important in stone disease. The luminal pH at the end of the proximal tubule is more acidic than plasma. And as such, most of phosphate is actually accepts a hydrogen and is in the monovalent form. And so this is our main form of titratable acid. And then, of course, we also have ammonia synthesis. So what about citrate? So citrate handling occurs in the proximal tubule. It's actually exclusively regulated by the proximal tubule. And interestingly, it's the most abundant base equivalent in the proximal tubular lumen. The divalent and trivalent forms are in equilibrium, but divalent citrate is the form that's actually transported and reabsorbed. So this secreted hydrogen actually binds the trivalent form of citrate. And then you see again this transporter that we met in the small intestine. This is actually characterized by Ann Major, and it's a sodium dicarboxylate co-transporter. It's an electrogenic process requiring active transport into the proximal tubular cell. So about 75% of the freely filtered, 75% of citrate is freely filtered at the glomerulus and then largely reabsorbed here in the proximal tubules. So we actually only get about 10 to 20% on average of citrate excretion. So what happens once citrate is taken up by the proximal tubular cells? So there's sort of two fates for citrate. Citrate is metabolized, so taken up by mitochondria, metabolized in the citric acid cycle. And then also there's this cytoplasmic ATP citrate lyase, which also metabolizes citrate. So under normal conditions, so say pH of 6.3 or less, there's negligible bicarbonate in the urine. Citrate is, again, the main mode of alkali excretion and the only organic anion in millimolar quantities in the urine. It exists predominantly in the trivalent form. And then importantly for stone disease, and really the reason why we're talking about it is that it is a very effective chelator of calcium. And so for that reason, a very important urinary anion. It prevents precipitation of calcium with phosphate and oxalate by forming these very soluble complexes, and in so doing inhibits spontaneous nucleation and crystallization. All right, so sorry, these slides got a little bit messed up. So we're going to talk about factors influencing urinary citrate, talk a little bit about chemistry. So these next few slides, I'll talk about different factors influencing citrate excretion and some of the early studies that looked at this. So the upshot of all the studies that have been done is that urinary citrate is influenced by acid-base status. And after Krebs described the citric acid cycle in the 30s, physiologists were keenly interested in sorting out the chemistry behind urinary citrate excretion. It was recognized early on that citrate excretion was influenced by acid base. So this is just, I put this slide up just to demonstrate, one of the studies, if we look back over almost, the past century, a lot of really nice physiologic studies. This is one basically involving one subject on a mixed diet, and then this individual was given different things, forced to do vigorous exercise and take sodium bicarbonate and ammonium chloride. And I'll just point out one of the findings, which is, with ammonium chloride load, there was a drop in urinary citrate. Again, it's one person, so we won't delve much more into the rest of the graphs. And I have this slide up just to show that during his time in London, Dr. Scribner actually also studied effects of acid-base balance on urinary citrate in the rat. So in the interest of time, I won't review all of the studies spanning the last almost century, but we'll summarize saying a number of studies have shown that citrate excretion is regulated by changes in pH, and that acidosis decreases and alkalosis increases citrate excretion in the kidney. So, how does this happen? So what are some of the proposed mechanisms? And, there has been a lot of investigation in this area and a lot that still needs to be sorted out. But we do recognize from a lot of clinical studies that metabolic acidosis reduces urinary citrate by increasing citrate reabsorption. So how might that happen? So the one observation is that with a lower tubular pH, this will increase the concentration of divalent citrate. And of course, that's the citrate, the form of citrate that's available for reabsorption through this sodium transporter. So acidosis has actually also been shown to increase the activity of the transporter, and that's independent of the citrate concentration. And also in the setting of acidosis, there's actually increased intracellular metabolism of citrate. So some direct effects on transportation of citrate into the mitochondria and upregulation of the different enzymes that metabolize it. And in so doing, both pathways result in generation of bicarbonate, which is essentially equivalent to less base excretion. So as you would expect, we would expect the opposite from metabolic alkalosis. And this is really the tenet behind alkalinizing the urine in metabolic stone disease. So what has been observed in studies is that there is less citrate metabolism in the setting of alkalosis. So again, in contrast to the situation in acidosis, there's actually decreased activity of the enzymes involved in citrate metabolism intracellularly. There's more trivalent citrate. And then where there is still confusion and sort of some unknowns and areas of investigation is, which pH is important? Is it the luminal pH or blood pH and acid-base balance systemically? And that's unclear. It's sort of an unresolved issue, how renal tubular cells may sense acid-base status. And what's interesting, and the reason this has come up is because acetazolamide, which essentially alkalinizes luminal fluid, but causes a metabolic acidosis, is associated with less urinary citrate excretion. All right, so what about etiologies for low urinary citrate? And how do we define it? So sort of looking at, all the different studies, that have been done in stone formers, the consensus in terms of, defining low urinary citrate as a urinary citrate less than 320 milligrams a day. And it's a very common metabolic disturbance in stone formers, affecting about 20 to 60% of stone formers. So when we see it in our patients, what should we be thinking about? And in light of, what we've discussed and the effects of acid-base imbalance, we certainly want to look for underlying causes of metabolic acidosis. So first and foremost, most cases that we see are going to be idiopathic, but we certainly always talk to patients about diet, and I'll follow with some studies looking at how protein, diets that are enriched in animal protein do lead to an acidosis, which can lower urinary citrate. But additionally, we want to think about conditions like a distal renal tubular acidosis. Oftentimes, we'll see patients with more of an incomplete RTA. So we sort of detect it based on urine chemistries. So looking at the 24-hour urine collection and seeing high urinary pH and low citrate. Oftentimes these patients will have normal serum bicarbonate and potassium. Topiramate is definitely a medicine that, and zonisamide, which I didn't put here, but there are two medications that we always ask stone formers about, especially when we're seeing hypocitraturia. So topiramate and zonisamide are carbonic anhydrase inhibitors, and essentially they produce, in terms of urine chemistry, a distal RTA. And most patients, and a large number of patients, do develop essentially either a complete or incomplete RTA on topiramate, but it's estimated that probably only about 1 to 5% of patients develop kidney stones. Of course, chronic acidosis from diarrhea, malabsorption are conditions that we want to ask patients about. So malabsorption in terms of any inflammatory bowel disease. This next one is actually really important. So many of our patients, when we're treating metabolic stone disease, will reach for a thiazide diuretic, and very commonly patients become hypokalemic. And then when you get their next urine collection, and hypokalemic might just be, serum potassium of 3.5, 3.6, but it actually does significantly affect urinary citrate. So you get the next 24-hour urine collection and you'll see a lower citrate. So we actually treat patients on thiazides to a potassium of 4. We want their potassium to be at least 4, and actually magnesium similarly to be at least 2. Strenuous physical exercise has been described, and then obviously that would be from a lactic acidosis. And then something else to keep in mind in your patients with struvite stones who may have a urease producing bacteria, those bacteria actually degrade citrate, so you'll often have very low urinary citrate, and of course in those cases the tip-off also is a very high ammonium level. So, this is a lovely study. A lot of the data looking at urinary citrate and treatment, it comes from Charles Pack and his UT Southwestern group. So this is a study essentially looking at the effects of animal protein. And so animal protein, essentially, methionine and cysteine are metabolized into sulfuric acid. So we're essentially getting an acid load. So, and that, if we think about a Western diet, most commonly people will be experiencing an acid load with their food intake. So how does that affect urinary citrate, and why is that important in stone formers? So this was a study of 15 adults, men and women. They actually did not have stone disease. What was fixed in terms of their dietary intake for the study was calcium intake, sodium and phosphate, and they were also on a fixed amount of protein of 75 grams. But the sources of protein differed among the 3 groups. So we have vegetarians, ovo-vegetarians, which is vegetarians eating eggs, and then of course patients eating animal-based protein. And so what you see here is that if we look, we'll just focus on the sulfate. So you see a significant increase in sulfate, an increase in the net acid excretion, and a decrement in pH on this diet. And then importantly, and what the study is trying to show is that along with that, you get a decrease in urinary citrate. So and I'll comment also that there's, you know, an observational study by Gary Curhan's group showing that the more, so looking at diet, it's observational, looking at diet among stone formers, and that showed that the more DASH your diet, the lower your risk of forming additional stones. So it was, you know, out of this study that Charles Pack essentially started, working with Mission Pharmacal on developing Uracid K. So that was actually developed in 1985. And we'll talk a little bit more about that as we go on in the next few slides. This slide is just an example from my clinic of showing kind of this showing that this is actually something we see. So this is a gentleman who admittedly eats a lot of meat, but even if he didn't tell me that, we can see from his urine that you know, and this is why these dietary factors are so helpful, but very high phosphate, ammonium, sulfate, urea nitrogen, protein catabolic rate. So all markers of high protein intake. And you know, he wasn't, this individual was not hypocitratouric. And so, but what I want to point out is the, you know, the citrate before and after a reduction in intake of animal protein. So 837 with a lower pH, but then with less meat intake, you see everything sort of go the other way. So lower protein intake as reflected by the dietary factors, and then higher urinary citrate and higher pH. Another very critical thing to point out with high intake of animal protein and the acid load is that also results in increased calcium excretion. So you also actually see the calcium, a decrement in calcium in his follow-up urine collection. So what about strategies for treating hypercitraturia and kidney stone disease? So I've alluded to this. So this was a study looking, this is again led by Charlie Pack's group, treating 8 stone patients with basically potassium. So they either distilled water, so it was 18 days of treatment, and there were 4 phases. So water, potassium chloride, potassium bicarbonate, and potassium citrate. They were all treated with 80 milliequivalents daily. It was liquid as opposed to pill. And essentially what the study showed, the take home from the study is that both potassium citrate and potassium bicarbonate are effective in increasing urinary pH and citrate excretion. So the take-home point here is that, you know, there's nothing magical about giving citrate. The point is urinary alkalinization. That is what improves or increases citrate excretion, and we've sort of shown the mechanism as to why that might be happening. And so you get the same effect on a millimole to millimole basis if you give, you know, sodium bicarbonate, potassium bicarbonate, potassium citrate, sodium citrate. And so that's really sort of the main take home from this study. And so you see that here's control, potassium chloride, potassium bicarbonate and potassium citrate, and essentially the main finding is the higher pH in the citrate and bicarbonate group and the higher citrate. And this is important because I've certainly had the experience too many times where I prescribe potassium citrate or potassium bicarbonate and the pharmacy fills potassium chloride. And so, that's dangerous and ineffective. So it was sort of predicated on these types of findings that, again, Dr. Pack teamed up with Mission Pharmacal, and that's when we had the development of Uracid K. So that was approved by the FDA in '85. So a very effective medication, but one that's difficult on many levels for our patients to take. Mainly cost. It's actually rare that I don't have to fight an insurance company for that medication, and also GI side effects. So it's actually can be quite tough on the stomach. And that's just a molecular structure of Uracid K. So because of the problems with Uracid K, cost, GI, and then maybe potassium loading, there was a lot of interest in lemonade. And so this was sort of like big news. Marshall Stoller's group from UCSF took 12 patients and gave them 4 ounces of real lemon. So that's that squeezy lemon juice with 2 liters of water. And they measured urinary citrate at baseline and then 1 week later, and essentially observed that they had increased urinary citrate. So this was really exciting. Everyone should put lemon juice in their water. And they sort of proposed that, that 2% of citrate, that doesn't get metabolized, that's showing up in the urine, and that's a meaningful finding. And then, this was another study, and it was sort of just retrospective, looking back at patients that had received or taken lemonade, and they also had increased urinary citrate. And then, again, the Southwestern group looked at this and sort of confirmed that, well, yeah, that's just the citrate that's not metabolized. And, is that really efficacious? And so the important point here is that, in theory, lemonade should not really raise urinary citrate. And so when we're thinking about urinary alkalinization, the important points are that we need to consider, not just the bicarbonate or citrate, but what is the alkali potential? So what is the pH of the solution? And then what is the total alkali? And it might not just be citrate or bicarbonate. When we think about a lot of the commercially available drinks, they also have something called malate. So the point with this is that it really doesn't make sense that lemonade is effective. The pH is only 2.7, and essentially it's, when it's metabolized with a proton. So it's sort of a neutral effect in terms of acid-base balance. So in the interest of time, I'll just go through the last few slides, but this again is just a really nice study demonstrating this point. And so this is a study looking at orange juice versus lemon juice. They kind of manufactured the juice and made it have a citrate content of 100 milliequivalents. But the point is that orange juice is acidic, but not as acidic as lemon juice. And as you can see here, lemonade. Lemonade did not really have any effect on urinary citrate, whereas this orange juice concoction did, and similarly with urine pH. So frankly, lemonade just really doesn't work that well. And again, as I've said, to raise urinary citrate, you need to alkalinize the urine. So you need to consider total alkali. And it's important also to keep in mind that the accompanying anion is one that's readily absorbed. So a lot of people ask about, well, why don't we give magnesium citrate or calcium citrate? And the reason is that neither magnesium or calcium are absorbed well in the intestine, while, as we know, sodium and potassium are absorbed very well. And then the other important point to think about is that the pH has to be high enough to confer an alkali load. So I'll just go, just to let you know that so John Asplund, who's the medical director at Litholink, has done a lot of studies looking at what is the alkali potential in a lot of commonly consumed drinks. And just to point out this lemonade formula from the earlier study, I mean, essentially in terms of milliequivalents per liter, very low, so 6 milliequivalents per liter. And the winner in this study was Diet Sunkist Orange. Sorry, that was just what the mixture was for that lemonade formula. And then I got these slides from Dr. Asplund, so he is fine with me sharing this, and he's essentially just, I think, has had a field day with measuring alcohol potential in different beverages, and so you see things like, Tropicana is very high, Simply Orange very high, but of course the problem is the sugar, so we can't really, prescribe this to our patients. More recently, so he had noted before that Nirvana coconut water had 13.6 milliequivalents, and then recently published this study where he had some volunteers that drank 2 liters of coconut water a day for 4 days and had an increased urinary citrate by their urinary citrate increased by 29%. The take home with this study that I just want to point out is just that it doesn't take weeks to raise your urinary citrate. So again, this was on day 3 that you see an increase. So it should happen very quickly. And so just a few more drinks. Crystal Light lemonade is cheap, so 17 milliequivalents per packet. And then the title of my talk includes something called Moonstone. And so Moonstone is sort of the new kid on the block. And when I first got this slide, it was still a sort of a coded chemical number, but anyway, so now it's been marketed. So Moonstone is the brainchild of Marshall Stoller and David Goldfarb, who worked with industry to develop this. And of course, it has a lot of alkali. And these are just some other options, things that I'll prescribe, F/K, which is 25 milliequivalents of potassium bicarbonate, and then something you can buy on Amazon, which is food grade citrate, potassium citrate. So just an option for patients. So I'm running over time. This was my patient on his insurance did cover potassium citrate. So you see the improvement over time. And the important thing with treatments is just following urine chemistry. So, but you don't have to wait a few months to do that. So my take home points are, when you see your stone patients, certainly idiopathic hypercitraturia is common, but evaluate for secondary causes. They're better options than lemon juice for alkalinizing the urine. Encourage plant-based protein over animal-based protein, and consider some alternatives to potassium citrate when costs or GI distress are an issue. Thank you, and I just wanted to acknowledge Dr. Asplund, who this is a picture of us in front of Litholink in Chicago in 2018 for a stone camp. So, I've learned a great deal about stone disease from him. So thank you, and sorry for running over a little bit.
Thanks so much, Fionnuala. Really appreciate it. I think maybe we'll have time for one question from Brendan. So he asks, is divalent citrate a proton donor? And so do dietary sources or the citric acid your kids were playing with or that you get in Indian grocery stores differ in their content of trivalent and divalent citrate?
Okay, so sorry, let me say that, is it on the chat here?
Yeah, it's in the chat.
Okay, let me just read that. Okay. So the answer is yes. So the pKa so there's sort of 3 pKa's. So for trivalent it's 6. I think for divalent it's lower, around 4, and then monovalent about 2. Yeah. So that's the Kiwi kit, citric acid and sodium bicarbonate, and making explosive things. The Indian grocery store. Oh, so right. So Brendan's talking about, Brendan found this formulation at a store. Brendan, you'll have to remind me, but it was somewhere in northern Washington. And I don't know. I believed trivalent is what the commercial is trivalent. That's what's in Uracid K. So I would say it's the same.
Great. Unfortunately, I think for the purpose of time, we'll have to move on. Thanks so much, Dr. Cormack. So I'll turn things over now to Dr. O'Hare, who will introduce our next speaker.